fellowship, I worked as an academic hematopathologist. So before I begin the heme path overview, I'll give you a little bit background and experience about my career path. And then I'll talk about the hematopathology as an overview of what this field is. And then at the, I would say in the middle, about half, the rest of the half of the talk will be about case studies and some diagnostic tools that we use and how I approach the diagnosis in my daily life. So it's not going to be too much in depth about disease entities, but I'll just give you an overview of certain diseases and how, as a hematopathologist, we approach the diagnosis. So as I mentioned, I finished my fellowship in heme path. After that, I worked as an academic hematopathologist for about 15 years. And then I switched to a non-academic position. So I do have experience as a resident, as a fellow, as an academic hematopathologist, and now more as a non-academic in a commercial specialized heme path lab setting. And I can, if you guys have any questions about that, I can elaborate on it. I can talk a little bit about the switch as well, because that is something that not many people do, switching from an academic position to a non-academic position. And also, I have experience as a full-time pathologist and also as a part-time pathologist. So it all depends upon, what your goals are in your life. So pathology as a field actually gives you all these opportunities, depending on what your goals are and what you want to do. The switch from academic to a non-academic is actually not that hard. It's easier to switch from an academic pathologist to a non-academic as opposed to the opposite. So if you, after your training, you go into a private practice setting and you work in a private practice setting for like, let's say 5-10 years, and then, circumstances change and, you have to, or you want to go into an academic setting. In my experience, what I've seen is that, people have a little bit hard time switching from a non-academic to an academic position. But nevertheless, it depends on your motivation and your support system. It's, again, takes a little bit of time to get used to stuff doing in the academic setting. But from academic to a non-academic actually is a slightly easier switch. So most people, what they do is, right after fellowship, I would say that during your residency as a resident, you should have a pretty good idea whether you want to do academics or you want to do a private practice setting. So throughout your residency and your fellowship, you're going to hone your skills depending on what your future job or your first job is going to look like. If you are gearing yourself toward an academic, setting, it actually helps because you get a lot of support and a lot of experience in a multidisciplinary setting. And once you develop that skill, let's say if you spend 5-10 years in your academic setting, moving on to a non-academic or private practice setting is actually much easier. You're a bit more marketable because of your experience. But some people, they might have their goals set early on and they just want to do private practice from the beginning. So through in your residency and your fellowship, you kind of focus on a bit more general, overview of and knowledge and experience in pathology to kind of gear towards your private practice setting. And then once you're in private practice, some people just like to stay, for the rest of their life because it's their lifestyle. That's what they like. And also full-time versus part-time. I'm going to just talk a little bit about it. Most academic positions are full-time, so it's very difficult to get a part-time academic position. You can get it, depends on your goals, your negotiations, and support from the rest of the colleagues in your team. It is a little bit hard to have a part-time academic position. It's a bit more easier in a non-academic setting. But nevertheless, pathology gives you the opportunities to actually explore all of these different various career choices And you just kind of have to look for the right kind of place at the right time. All right. So, so I'm going to talk a little bit about heme path in general. And as you know, that hematopathology is a subspecialty of pathology that is, it's an accredited fellowship. Most programs have 1-year fellowship and some have 2-year fellowships. So you are actually trained to work in both academic and a non-academic setting in most of the fellowships. The subspecialties in pathology in general, they fall in either anatomic pathology type or clinical pathology side. Heme path is unique in that it actually is a combination of both anatomic pathology and clinical pathology. And if you look at the hematopathology division in any pathology department in an academic institution, they're usually built upon subspecialty labs that span through both the anatomic section and the clinical pathology section. So for example, you have the core lab, core hematology lab, which comes under clinical pathology. Then you have the flow cytometry lab and the bone marrow lab. That is an overlap between anatomic and clinical pathology. And then you have the cytogenetics lab, you have the molecular lab. So all of these labs are actually directed or supervised under the heme path section. And in hematopathology, we study specialized testing for patients for diagnosing leukemia, lymphoma, myeloma, and a lot of benign hematologic disorders as well. So in my day-to-day practice, I'm actually reviewing bloods, bone marrow, spleen, lymph node tissue, and any other tissue that is suspected to have involvement by any of the hematologic malignancies. Could be GI biopsy, could be a skin biopsy. Sometimes you get brain biopsies as well. And the broader diseases that we deal from day to day are like acute and chronic leukemias, the myelodysplastic syndromes, myeloproliferative disorders, plasma cell neoplasms, a lot of workup for anemias and other benign bone marrow lymph node disorders, and then evaluation of and diagnosis of B-cell lymphomas and T-cell lymphomas, and some cutaneous lymphomas as well. And as I mentioned that, as a hematopathologist, you're actually interpreting both routine and specialized testing that are performed in different sections of the lab. So you have the hematology core lab, you have some coagulation testing, flow cytometry, bone marrow, cytogenetic, and molecular lab. So it's actually a broader, pretty diverse setup when you're working as a hematopathologist. I'm going to talk briefly about the different types of tests that are done or utilized in a hematology lab setting. Briefly, I'm going to touch upon some of the specialized testing, but mainly I'm going to focus on the most common test that we do, which is a CBC and a differential count. And it's coupled with peripheral blood smear most of the time, and how much information we can extract from a CBC and a peripheral blood smear, and then all the stepwise reflex testing that is generated after you review the CBC and the smears. The other test that is very commonly done is the iron studies and B12 folate levels and the workup of anemia. And very commonly, we also see hemolytic workup in the setting of anemia to rule out hemolysis as an etiology. And then we have some coagulation testing. We do PT, PTT, and some special coag testing like mixing studies, factor assays, and Adams TS13 for specific entities like TTP, thrombotic thrombocytopenic purpura, and then mixing studies to look at factor deficiencies. On a day-to-day basis, in my job, I'm actually not involved in too much coagulation testing interpretation. I used to do that when I was in my first, university setting position, because in that the setup was that the coagulation lab was under heme path section. In some of the departments, the coag actually comes under transfusion medicine. So in my second position as an academic pathologist, the coagulation testing was mostly taken care by the transfusion medicine and the chemistry team. So it kind of overlaps. But I do a lot of, lymph node biopsy evaluation, bone marrow evaluations, flow cytometry, cytogenetic karyotyping, FISH testing, molecular testing, and then we also do a lot of next generation sequencing as well. So let's begin with CBC. And you all are familiar with what a CBC and a complete blood count is. So this is one of the most common tests ordered, and there's a lot of information that you can gather from this very simple test. It's usually done in two types of settings, in a laboratory setting, and then it also is done as a point of care testing. A point of care testing is any analytical test that's performed for a patient by a healthcare worker or caregiver or patient themselves, which is done outside the laboratory setting, and the result is available as a rapid result immediately without the sample being sent to the laboratory for analysis. And the purpose for the point of care testing is that we get rapid results for immediate patient care. CBC is one of the point of care tests that is done in a lot of the clinic settings. In the USA, about 20% of the labs are now being performed, laboratory tests are now being performed in a primary care healthcare setting. So CBC is not only utilized by hematologists and hematopathologists, but it's actually a test that is interpreted by a lot of our primary care colleagues as well. So as I mentioned, it's a very common test, and just to give you a number, the data from Mayo Clinic says that they do about 1,800 to 2,000 CBCs a day, which is a lot. So the core lab, which runs the CBC test through the automated hematology analyzers, even though it's done by the machine, there's a lot of process that goes on before the test is released to the patient chart, and I'll go through that process a little bit so you kind of have an idea where a pathologist's role comes in when this test is ordered. Because it's a very common test, it's actually comprises about 10% of laboratories' operational revenue on an average. And most family physicians are reasonably comfortable interpreting CBC results with marked abnormalities, and they may order some reflex testing up front after looking at the CBC. And sometimes you need a pathologist review to recommend certain specific tests. Results that show only subtle abnormalities or when the clinical picture is not clear, they may need some further guidance. So CBC actually is ordered based on some indications. So what are the indications for ordering the test? So usually CBC is coupled with clinical history and physical examination, and that's one of the first tests that is usually ordered after a patient is examined and the clinical history is taken. And it's done in two settings. One of them is a routine setting. With the clinical history and physical examination, everything is normal, but you may still order a CBC if the patient is coming in for an annual health checkup, or if there's a special population like with pregnancy or in elderly. On the other hand, if the clinical history and physical examination is showing some concern, or you have some indication that there may be some abnormalities that are leading to the symptoms of the patient, then the CBC is ordered. So symptomatic setting is usually fatigue, exhaustion, fever. Sometimes it's done to monitor the effects of medications like chemotherapy and growth factors, and then also to look at the severity of blood loss when their patients have whether the patients have any internal bleeding or not, usually post-surgery. And also prior to surgery, a CBC is done as a baseline. So those are generally the settings where CBC is ordered. And usually for a CBC with a differential count, the blood is sent in an EDTA tube. EDTA is a preservative that prevents the clotting of the blood. And when the blood is spun, usually you get three components. So at the top, you have the plasma. In the middle, the purple part, you have the buffy coat. And then you have the red cells that settle at the bottom. So what's in each component? You actually in the middle section, you have the white cells that settle after spinning, and these include the lymphocytes, neutrophils, monocytes, eosinophils, basophils, platelets as well. And then the rest of the cells are settled down here as red blood cells. So you actually have 7 types of cells that are going to be giving us information about not only the peripheral blood, but also what's happening to the factory that generates all these cells, which is the bone marrow. So essentially, when you're looking at a CBC and you're looking at a peripheral blood smear, you're actually looking at the health of the bone marrow to determine whether there is a problem in the production or the problem in the peripheral destruction of the cells. Again, just trying to move the gallery. Okay, so all of these cells, they are coming from a multipotent hematopoietic stem cell that originates from the bone marrow. So any abnormality that you see here eventually will give us clues about whether this is a peripheral abnormality or it's a bone marrow abnormality. So a CBC actually isolates and counts 7 types of cells in the blood, and it can reflect problems in fluid volumes such as dehydration as well. And it can show abnormalities in production, lifespan, and destruction of blood cells. So all the way from bone marrow to the peripheral blood. So I want to go over briefly about the evolution of blood cell examination. All right. So in the beginning, you know, when the first microscope was invented, this actually, it's not really clear who actually invented it, but the name that's given is to a Dutch scientist, Janssen. In the 1590s, the first microscope was invented, and with the invention of the microscope, then it was a beginning of the evolution of blood examination, because then the scientists, they started examining the blood cells of animals, plants, and humans under the microscope. But at that time, they did not have the means, facilities, or the technology to differentiate between different types of cells. But nevertheless, the microscope was able to magnify the cells to about 20 to 30 times larger. It was later in the, let's say, mid-19th century that a technique was developed to actually count the cells. So at this point, it was known that certain diseases are associated with differences in the cell counts. So it was done through a very tedious manual counting on a hemocytometer, which was a very thick glass slide. Would have in the center would have these etched squares, and then you put the blood on it, and then you count the cells based on where they fall in different squares, and then there was a formula, you calculate all the cell counts and get an estimate. Very tedious process. But at this point, the cells were not really stained, so you could differentiate a little bit between the red cells and the white cells, but you couldn't tell anything further other than their cell count. Then in the late 19th century, around 1878, Ehrlich, he actually came up with stains that help in differentiating different types of white cells. And that laid the foundation for future studies in hematology. Then in 1929, there was introduction of red cell indices. And red cell indices actually give a tremendous amount of information about the etiology of anemias and the health of the red blood cells and what morphology you may suspect in different conditions. So as you can see from early on, the evolution of the examination of the blood is actually expanding. So you're adding more and more different components to the examination. Then in the 1940s, first automated hematology analyzer was introduced, and that used a principle called the Coulter principle, which is used in many hematology analyzers today in combination with other new technology. So the Coulter principle basically was when the stream of blood would go through an aperture which had positive and negative current going through it. So when a cell passes through that, it gives two types of information. It's giving the information about the count. So every time a cell passes through, the current is disrupted, and a cell is counted. And the other information was about the size of the cell. So depending on the size of the cell, the change in the current would be different. So if it's a big cell, you'll see a big peak, and if it's a small cell, you'll see a small peak. So based on this information, you would get the cell count, and you get the distribution of the or the variation of the cells. Most of this is done for red blood cells and platelets, and usually you get what is called an RDW, which is red cell distribution width. So it gives a range of red cell size along with the red cell count. And then now in the new hematology analyzers, we have a bit of flow cytometry technology in which fluorescence is used, and also different antibodies are used to develop these plots and separate the cell types based on their size and their fluorescence. So we're able to separate and look at the cells based on their fluorescence, whether these are basophils, whether these are lymphocytes, they're monocytes. So they all are going to scatter in different areas of these plots. So this technology is used very commonly now in the hematology analyzers. So that's just a basic overview of the technology. So what happens when a CBC and automated differential is ordered? So a tube of blood is sent to the lab, and most of the labs have, one of the most commonly commercially used instrument is the Sysmex. And so the Sysmex actually, it runs the CBC with using all the technology, and then a graph or a report is generated by the instrument. And this instrument report is actually something that the lab has access to. And there are certain things that are checked in this report before it is transferred to the patient chart or the clinician is able to see it. And it's very important to have this step because there could be so many different things that need to be analyzed before a result is released. So I'm going to go over some of these components of a CBC report. So usually the instrument printout shows component of the cell count. So you have the full counts, the white blood cell count, platelet count, red cell indices as one component. And then you have the differential counts, 6-part differential count, and the nucleated red blood cells. And then some instruments will also give you information about the reticulocytes and immature reticulocyte fraction, usually helpful in the setting of anemias, whether they're hemolytic, the production problem, or it's a peripheral destruction problem. You also have the capability of measuring the reticulocyte hemoglobin, immature platelet fraction. And then you have, this component is used in doing a count on body fluid. So whenever you see this BF, actually it means body fluid. And in the instruments, you have the capability of running different types of samples. So if it's run on a blood, usually we just see the counts for the peripheral blood. But if it's run on, let's say, CSF or a pleural fluid, then we change the setting on the instrument to evaluate the fluid chamber, and then we get the body fluid counts like here. So the few steps that are actually taken after this printout comes out of the instrument is we look for flags. And those flags mean that there is something the instrument is telling us that you need to check before the result is released. And those flags are usually, or messages are usually highlighted at the bottom of this report. And then there are these different scatter plots that are usually for the technologists to just kind of double check that the populations are not obviously abnormal, or there is some sort of technical or an abnormality in the different cell components. So what we usually focus mainly is on the total counts and the differential counts. And all of these give us different types of information. So let's just focus on white blood cell count for a little bit. And so the white cell count gives us information about different diseases. And most commonly, you'll see changes in the WBC in patients with acute leukemias and chronic leukemias, chronic lymphoid disorders, chronic myeloid disorders, leukopenias, and neutropenias. So I'm talking in the setting of a heme path, but you can see white blood cell changes in a lot of other reactive conditions as well, for example, in infections as well. So after you look at the WBC or the total white count, pay attention to the differential count, and you have to know what the absolute differential count is. A lot of times I do see some clinicians, they focus more on the percentages. Percentages are okay to consider. However, you have to look at the absolute counts because a lot of the diseases are defined by the absolute counts. And then hemoglobin gives us information about anemia or polycythemia. Combined with MCV, it helps in the classification of anemias, whether it's microcytic anemia or macrocytic anemia, and those all have different differentials to work up. And then if you combine it with the RDW, the red cell distribution width, if there's a increase in RDW more than the upper limit of the range, and there is anemia with microcytosis, usually you see that in iron deficiency. But sometimes these features can also be seen in thalassemia trait. Usually in iron deficiency, you also have decreased RBC count. Thalassemia trait typically will have a normal range RBC count and very high RDW, along with microcytic hyperchromic anemia. And lastly, we have platelet count. So thrombocytopenia or thrombocythemia, which is also known as thrombocytosis. When you see these, then you have a different differential in mind to work up whether this is going to be secondary to an infection or is going to be part of a hematologic disorder. So that was just a basic overview of CBC and what different components indicate. And later on, when we do the case studies, then we'll show you some examples of how the diagnosis was approached. Now, after the CBC, there's a peripheral blood smear examination. The peripheral blood smear examination is most commonly tagged with the CBC, but it's not always done and it's not always necessary. The smear review is usually not indicated when the CBC is normal unless the patient is a known, oncology patient, and the hematologist, they are following up for certain subtle abnormalities that may not be shown in the CBC. But as a general rule, if the CBC is normal, usually smear review is not done. In the laboratory setting, after you see flags in the CBC from the instrument, there is a series of workflow that happens that can lead to eventually a slide being made and slide being reviewed by a pathologist. So any abnormal CBC parameters on automated hematology analyzers can lead to slide review, flags that are triggered by the instrument, and depending on the lab criteria, automatically a slide is made and is reviewed by the technologist and the pathologist. So here's a brief workflow. So after you see any flags or abnormalities in the instrument generated data, if the cell counts are too high or too low, and they meet the criteria for critical values, a phone call is made to the clinician and a slide is made. The technologists, they scan the slides just to verify those results, those abnormal results. And there are certain internal criteria that are set that have to be absolutely reviewed by a pathologist before the result is released, even before the CBC is released. And sometimes the CBC result is released after the technologist is satisfied and the criteria is met. So here are some indications of the smear review. And as I mentioned, if there are abnormalities in the cell count, most often a smear review is performed. And then there are some other diseases that also warrant smear review. Okay, another common test that I do in a day-to-day practice is a bone marrow biopsy. And you probably know or you've seen the actual procedure. It's an invasive procedure done at an outpatient setting, and posterior superior iliac spine. And the bone marrow biopsy has several components, and each component has its benefits. So you get a trephined biopsy, which is actually an actual piece of the bone or a core biopsy, and then you get some clot sections made. So both of these, the core biopsy and the clot section, are fixed in formalin, and they undergo the processing in the histology lab, and you get these slides with hematoxin and eosin stain. Now, the liquid part of the bone marrow biopsy, which is aspirated, usually the spicules are spread on the slide, and they're stained with the Giemsa stain, and sometimes we get touch preps that are made from the core biopsy, and we can gather some information from the touch preps as well. So you can see individual cells a little better on the aspirates and the touch preps, and you see an overall pattern of infiltration better on the core and the clot section. So bone marrow biopsy, again, is something that can be split in different, it can be triaged and split to perform different ancillary testing. In addition to morphology, we can do immunohistochemistry, flow cytometry, cytogenetics, and molecular studies. Again, bone marrow biopsy should not be done just for any reason. For example, patients who have severe anemia and iron studies indicate that there is severe iron deficiency anemia or B12 folate deficiency. In a nutritional deficiency setting, bone marrow biopsy is not indicated. But if you have ruled out all the other causes of anemia that could be in a peripheral setting, then a bone marrow biopsy is indicated, because a lot of the hematologic neoplasms, they can present with anemia, like infiltration of the marrow by lymphoma or a myelodysplastic syndrome, or even acute leukemia. So if you're suspecting acute leukemia, the bone marrow biopsy is done. It's also done in investigation of myeloproliferative disorders. These are disorders where the bone marrow is producing cells that are in excess, and they are spilled in the peripheral blood. So the counts usually are very high in these patients. So bone marrow biopsy gives a good idea about the different subtypes and helps in the classification. Patients with multiple myeloma, which is a plasma cell neoplasm, also get a bone marrow biopsy, and certain lymphomas will get a bone marrow biopsy for staging purposes, even if the CBC is normal. So that's just a standard of care if the patient has a diagnosis of lymphoma. Lymph node biopsy, I'm going to briefly talk about how we triage the lymph node biopsy in a path lab. And similar to bone marrow biopsy, we have to split the lymph node biopsy in order to get the maximum amount of diagnostic testing and data to come up with an accurate diagnosis. If a patient has a suspected lymphoma, usually we, in the labs, we have a protocol that is set up to send the lymph node fresh, which means a lot of times when the tissue biopsy is taken in the OR, usually it is put in a fixative, which is formalin, and then it's sent to the lab. But if it's suspected lymphoma, our surgeons, they know not to put it fresh, because there are certain steps that are supposed to be taken in the lab to triage that lymph node. So here's an example of a lymph node which was sent fresh. So it is cut in several thin sections or bread loaf, and different ancillary techniques are used. Nowadays, because of the advanced technology, the diagnosis actually has transformed. So in addition to morphology, we routinely do flow cytometry, cytogenetics, and molecular in a lot of the hematologic disorders. So morphology is usually, for morphology, the portion of the lymph node is usually fixed in formalin, and then a section is made. From this section, we can do immunohistochemistry. Another component is flow cytometry analysis. For this, the tissue should not be fixed, and it's usually taken fresh from the lymph node and put in a specialized medium called the RPMI medium. And then it is processed in the flow cytometry lab to get the flow cytometry data. Similarly, for cytogenetics and fish studies or fluorescent in situ hybridization, it is preserved in RPMI medium before it is fixed in formalin for morphology, and then you get the cytogenetics and karyotyping data. And then for molecular analysis, you can actually do it on fixed tissue, or you can do it on frozen tissue to get your molecular data. So this case actually, I'm going to briefly give you an overview. This is an example of a type of lymphoma called follicular lymphoma. So on the this first slide is the hematoxylin eosin slide, H&E slide. And what we see is these big nodules that are abnormal, and they're back to back. And there's a specific immunostain that is done, and it's highlighting the center part of these nodules, which is called the geminal center. And this is a BCL2 stain. So just based on the morphology and the immunostain, a pathologist or hematopathologist is pretty confident that this is a follicular lymphoma. But we also have additional information and data that's coming from flow cytometry, cytogenetics, and molecular. So let's see if all of this fits in the diagnosis of follicular lymphoma. So what flow cytometry is showing is actually this population, which are all the B cells. So this is a type of a B cell lymphoma that are lambda positive. That means they are clonal. So it's the flow cytometry is abnormal. Cytogenetics is showing, you can see with these arrows, actually showing a 14-18 translocation. So this lymphoma is characterized by 14-18 translocation, and same result is shown on the fish picture over here. And then molecular analysis shows that, in this B cell lymphoma, the B cells actually are clonal because you see this one single peak, so it's a clonal peak. So all of this data is indicating this is a neoplastic or malignant process, not a reactive enlarged lymph node. Now, are all of these techniques necessary to make a diagnosis? Not always. We don't really need molecular if we have morphology, immunohistochemistry, and FISH or flow cytometry. So we can make the diagnosis if we have like maybe 2 out of the 4 or 3 out of the 4. But sometimes it's helpful to have all of this data up front in a diagnostic case, because when this patient may come back as a relapse and only a small portion of the lymph node is involved, and it's difficult to differentiate between reactive versus malignant based on morphology, we can use all these techniques to go back and see that if that abnormality is still present or not. So it helps in the subsequent diagnosis and follow-up as well. Okay, so I do have a series of about 5 cases that will go over the different diagnostic approach and tools that we use to make the diagnosis. And everything is going to start from CBC. So first case is a 21-year-old female. She presents with fatigue and left upper quadrant pain. She has no other symptoms. The physical examination showed a palpable spleen. A CBC with differential and ultrasound abdomen were ordered. And when we look at the total counts, the white count is normal, hemoglobin is normal. The only abnormality that I see here is slight thrombocytopenia. So you have platelet count of 145. Then we look at the differential count. Even though the total white count was normal, we do see some abnormalities in the lymphocytes. So the absolute lymphocyte count is high. So this CBC is actually showing thrombocytopenia and lymphocytosis. So when this abnormality is seen, the lab action is to perform a peripheral blood smear review. And a differential diagnosis based on that CBC in a 21-year-old female could include reactive lymphocytosis, it could include acute lymphoblastic leukemia, or it could include any of the chronic lymphoid leukemias that can raise the lymphocyte count. So before looking at the slide, as a hematopathologist, usually we come up or we formulate a differential diagnosis, kind of narrow it down to see what we are thinking. Now, in this 21-year-old patient, the first two are possible because these are more common in younger patients. The chronic lymphoid leukemias are usually seen in more older individuals or elderly, so less likely to have any of these. So what do we see in a peripheral blood smear review? So peripheral blood showed these different types of cells. So the first one on the left side is called a LGL, which is a large granular lymphocyte. This is a type of a lymphocyte that has abundant cytoplasm and has these granules in the cytoplasm. So it's, for the most part, it's considered a reactive expansion of a lymphocyte subtype. This patient also had some cells that look like this. They have a very dark blue cytoplasm. They have some small nucleoli, but still has abundant eccentric cytoplasm, very different than LGL. So keeping this cell in mind, we look at what else is there. So there's another cell that actually has a lot of cytoplasm, and it's kind of scalloping around these red cells, and it does have a big nucleolus. And so what these cells are, actually, these are subtypes of reactive lymphocytes. They're called Downey type 2 and Downey type 3 cells. So when you see a lymphoid population with these variety of cells, which we call, the term that we use is called a polymorphous expansion. And then there is a monocyte population that is also showing some vacuolation and some granules, which is mature. So all of this combination of these findings actually led to this comment from the pathologist. So this patient's peripheral smear review shows mild thrombocytopenia and lymphocytosis composed of numerous reactive large lymphocytes and rare atypical lymphocytes of Downey type cells. Now, the combination of this feature, just by looking at the cells, it suggests that there is a viral infection such as EBV and recommended EBV serology. So the reflex test that was triggered after this included a monospot test, which is looking at the antibodies that are generated in patients with infectious mononucleosis, and EBV serology. Both of them were positive. So this patient actually has enlarged spleen and presented with fatigue, left upper quadrant pain because of splenomegaly. Sometimes they do have some upper respiratory symptoms. This patient did not, but does have all the confirmatory tests for infectious mononucleosis. So this patient was given a diagnosis of infectious mononucleosis, was treated accordingly, and no further testing was done. Well, this case number 2 is slightly different. This is an older female, 68-year-old female. She presented to her primary care again for a routine physical. She is asymptomatic, and her physical exam was normal. Now, the CBC was performed, even though there was not much information from the clinical history and examination, just because she is an older individual, was done as a routine. So on this routine CBC, there was an abnormality seen, which was an elevated white cell count. And we look at the differential count, again, you have lymphocytes percentage is increased, 80%, neutrophil percentage is decreased, but the absolute neutrophil count is normal, and absolute lymphocyte count is abnormal. So this patient also has leukocytosis with lymphocytosis. Again, peripheral blood smear review is performed. And the thought process is the same. Patient with lymphocytosis, you think about, could it be reactive? Could it be acute leukemia? Or could it be any chronic lymphoproliferative disorder? In this patient, there are chances that it might be one of these chronic leukemias or acute lymphoblastic leukemia, and less likely to be a reactive lymphocytosis. So the peripheral blood smear review in this patient is showing many lymphocytes that are small in size. So the size is determined by their comparison to red blood cell. So the lymphocyte nucleus is usually about the size of red blood cell or slightly higher, maybe 1 or 2 times the size of RBC. And these cells have very round nucleus. They have very dark condensed chromatin. And all of these cells, except this one, they look exactly like the other. So this is called a monotonous population. And there's this one cell that's slightly larger with a little bit more cytoplasm, which is also an abnormal cell. So this patient has absolute lymphocytosis with atypical monotonous lymphocytes with clumped chromatin, and it's consistent with the chronic lymphoproliferative disorder. In this patient, flow cytometry study was recommended for confirmation in immunophenotyping. So here we are looking at a different type of reflex testing. Patients who have lymphocytosis that does not look reactive usually should be referred for hematology consultation. And they usually order the flow cytometry and additional testing based on pathologist recommendations. So this is this is data from flow cytometry on this patient. And I'm going to go over a little bit slow on the plots here, so that just to give you an idea how we analyze these. So flow cytometry essentially is a technique in which you're looking at the surface antigen expression of the cells. So you're not looking at the cells based on their morphology, you're looking at the cells based on their expression. And flow cytometry helps us identify the lineage of the cells, whether these are B cells or they're T cells or they're blasts or there's some other cells. Based on a set of markers that are present, we can define the lineage of the cells. The B cells are usually positive for CD19 and CD20. These are the B cell markers. And usually they have either kappa or lambda expression. These are the light chain expression. So here, the purple population are all the B cells, and you can see that these cells are 19 positive, and then 20 expression is, it's a little bit, you see how this shape of this population is a little bit oval. So that means they are, the 20 expression is a bit variable from low to a little bit higher. So it's this we consider dim to low 20 expression. And in addition to the 19 and 20, which are B cell markers, this purple population is also expressing CD5. Now notice that there is this red population. These are all the T cells that are present in the blood. So even though we're not studying the T cells, it does help to view the T cells and what they are doing to make sure that the antibodies are working fine. So CD5 is normally a T cell antigen. It's present on all the T cells normally, and it's never positive in normal B cells. In certain B cell lymphomas, there is some abnormality that leads to the expression of CD5 in the B cells. So here you can see the T cells are CD5 positive, but the B cells that are 19 positive are also 5 positive. And when we look at the kappa and lambda, which are the light chains, all of the cells are lambda positive. Normally, you should have some kappa and some lambda, which is called a polyclonal. Here, since all the B cells are just producing one type of light chain, this is considered clonal or a malignant process. So the flow cytometry phenotype shows CD5 positive, CD19 positive, dim CD20 positive, CD23 positive, and actually this should be lambda, sorry, this is a typo, lambda positive population. Based on the phenotype and the morphology, the diagnosis is chronic lymphocytic leukemia. So in this patient, we were pretty confident based on the CBC, peripheral blood flow cytometry. This patient has CLL. Now, a FISH study was also done in this patient. And in the FISH analysis, usually we look at different parts of the DNA on different chromosomes. And in CLL, there typically a very common abnormality that is seen is deletion of chromosome 13, Q14, long arm of chromosome 13. And in FISH technique, usually it's called fluorescent in situ hybridization. So we're looking at the presence or deletion of different components of DNA fragments on the chromosomes that are hybridized with known DNA probes that have fluorescent labels. So when a cell is actually analyzed under the microscope for the FISH analysis, what we're looking at is actually the nucleus, and the nucleus will have these signals. So a normal signal in this, if this is not a CLL, a normal signal should have 2 red and 2 green signals because there are 2 chromosome 13s. So the red is actually one part of the chromosome that is labeled, and green is another component of chromosome 13 that is labeled. So this is a normal one, and then this is the leftover portion of the chromosome 13 that has the red part that's not there anymore because that 13q14 part of the chromosome is deleted. So this is showing a deletion of 13q. Another probe that is used in differential for CLL is the IGH-CCND1. This is a typical abnormality that is seen in mantle cell lymphoma, and it's important to differentiate CLL from mantle cell because there is morphologic overlap, and the prognosis and the treatment is different. So the IGH-CCND1 probes, they show that you have 2 red and 2 green signals. So this is a normal study. So it's negative for the IGH-CCND1 fusion. So based on this finding, actually supports that this is a CLL case with deletion 13q. Right, case number 3. This is a 58-year-old male who presents again for routine physical, asymptomatic. The white cell is shown, the total white cell count is very high, so about 20,000. And then the differential is showing absolute lymphocytosis again. So this patient has leukocytosis with lymphocytosis. Peripheral blood smear review is showing these cells that are slightly different than the case number 2. These cells actually have nuclear irregularity. If you can appreciate that there's actually a dip or a cleft in the nucleus and folds in the nucleus. Here again, if you trace the edge of the nuclear membrane, you'll see these dips and clefts. So these are subtle changes that pathologists, they are actually used to identifying on the smears, and they can identify these atypical cells circulating in the peripheral blood. So once you see these atypical cells, then again, flow cytometry is recommended in this patient. And as opposed to the prior case, this is CD19 versus CD20. So in this case, the CD20 is not a oval shaped spread from low, medium to high. This is actually pretty high CD20 expression. So going on the right actually indicates it's a very strong intensity CD20. So it's a bright CD20 with 19. And then the kappa expression is also moderate. Again, this case is also CD5 positive. So this patient phenotype is showing CD5 positive, 19 positive, bright CD20, and moderate kappa. And based on this phenotype, pathologists can tell that this could be an atypical CLL or it's a mantle cell lymphoma. So there are 2 differentials. They've narrowed it down to these 2 types of lymphomas. So how do we differentiate between the 2? Is again, we do the FISH study, and mantle cell lymphoma is defined by the presence of this translocation 1114, which is tested by doing this FISH analysis for IGH-CCND1. So the IGH gene is on chromosome 14, CCND1 is on chromosome 11. So normal cell, as we saw in the other case, for the IGH-CCND1, you should see 2 green, 2 red signals. Here you are seeing 1 green, 1 red, and 2 yellow signals, meaning that the translocation has happened. And when the IGH and the CCND1, they come close to each other, that gives a yellow signal. So this indicates that there was this translocation present, and this is not an atypical CLL. So this case was diagnosed as mantle cell lymphoma. Case number 4 is slightly different. This is a patient who is 67-year-old who presents with some fever and fatigue, so some symptoms, mild splenomegaly, no lymphadenopathy, and CBC is performed. So this patient, as opposed to the other 3 cases we reviewed, the white count is actually low, and the hemoglobin is also slightly low. And in the differential, the only abnormality that you see is neutropenia, absolute neutropenia. So this patient has anemia and leukopenia. The smear review in this patient shows these rare atypical cells that are lymphocytes that have these very funny hairy cell projections. Okay, so this is a very typical morphology, a unique morphology that if you, can identify, can help you in the diagnosis further down the line. So after seeing these atypical lymphocytes with cytoplasmic projections, flow cytometry was performed. And in flow cytometry analysis, this patient has 2 types of B cells. So the purple population are your normal B cells, and this black event, so black dots are actually those hairy cells that we saw on the peripheral blood. And if you follow the phenotype of these cells, they are actually very bright for CD11C. So here's CD19. So these are the 2 types of B cells, normal B cells and your lymphoma cells. They're 11C positive, they're CD25 positive, CD103 positive, and then on the kappa and lambda, they're all lambda. This is a very typical phenotype, a very classic phenotype for hairy cell leukemia. So just based on the morphology and looking at the flow cytometry phenotype, we can actually call this hairy cell leukemia. So this patient underwent a bone marrow biopsy. And in the bone marrow, this is an H&E section of the core biopsy where we see some megakaryocytes and some erythroid precursors, very difficult to differentiate where the lymphoma cells are. Maybe some of these cells here where you see some clearing of the cytoplasm, but it's a very subtle infiltrate. So in order to bring up or highlight the infiltration of the B cells, we do a immunostain. So here is a CD20 immunostain. And you can see that there are actually a lot more lymphoma cells than what we were able to see on the H&E. So this patient's bone marrow is involved by hairy cell leukemia. So now hairy cell leukemia is characterized by a very specific mutation, which is present in more than 95% of patients, and it's called the BRAF mutation. And this particular mutation is, again, it's diagnostic for hairy cell leukemia. And again, helps in differentiating it from other types of B-cell lymphomas. Lastly, the case is about a 42-year-old male who presents, so he's symptomatic, he's presenting with fever, fatigue, night sweats, and again, fullness in the belly. Physical exam shows a palpable spleen. There is no lymphadenopathy. Ultrasound and CBC is performed. This patient has a very high white count and has mild anemia. And looking at the differential, the white count is actually not because of lymphocytes this time. It's mostly because of the neutrophils. So there's a lot of neutrophils, the neutrophilia. And then in the differential, you also see some immature cells in the neutrophilic lineage. These are myelocytes and metamyelocytes. There is also eosinophilia and basophilia. So this patient has anemia, leukocytosis with left shift. And left shift means that we're starting to see some immature cells in the peripheral blood. So normally, you should only see mature cells in the blood. There are very few reactive conditions in which you can see immature cells. Typically, when you start seeing immature cells in the blood, it's concerning for a leukemic process. So peripheral blood smear in this patient was done, and you see a lot of these are mature neutrophils with these multiple segments of the nucleus. But along with those, you are also noticing some cells that are slightly larger. They have a bit more immature nuclei, more rounded oval nuclei without segments, and they have some granules in the cytoplasm. So these are the myelocytes. So when you see myelocytes, metamyelocytes, and a rare promyelocyte, so this is very concerning given that very high white count, about 54,000, very concerning for chronic myelogenous leukemia. So a FISH analysis for this specific fusion, BCR-ABL fusion, is recommended and a hematology consult is done. Now this patient, in this patient, now the hematologist has a choice. They can either do all the testing in peripheral blood, but eventually this patient should get a bone marrow biopsy because these chronic leukemias can sometimes have more immature cells in the bone marrow than what is seen in the peripheral blood. So that can also help define the stage of the disease, whether this is an accelerated stage of becoming an acute leukemia. So bone marrow biopsy is usually done in these patients. So here I will switch a little bit towards, and this is the last component of my talk, is, if a bone marrow biopsy is done in this patient, it gives a lot of information, and the bone marrow biopsy has different components in it that are compiled by the pathologist after gathering information from all the ancillary techniques. We also look at the cell counts. So all of this information is very important in formulating the diagnosis. So if a bone marrow biopsy is done, this is a patient with CML. Usually we report the peripheral blood smear review and we report the bone marrow analysis or evaluation in the same report. So you have a very hypercellular marrow. The marrow is going to be packed with those immature cells, and the diagnosis has already been made as chronic myeloid leukemia. The comment usually gives an information about how this diagnosis was made. So we talk about what we are seeing: marked myeloid hyperplasia, there is basophilia, there is some abnormality of megakaryocytes, slight fibrosis, and then the molecular study was performed and it was positive for the P210 BCR-ABL fusion. This is the key for making the diagnosis if you identify this fusion. So this is consistent with the chronic myeloid leukemia in chronic phase. The FISH study was pending in this case. So later on, when we get the FISH study, we add it to the report. Here is a flow cytometry report. In this case, I didn't show the histograms because usually the features are very subtle in chronic myelogenous leukemia. And, with experience, we kind of have some idea about the expression of different myeloid antibodies, 33 and 34, and their maturation pattern. So in this patient, there were some abnormalities, and based on that information with the abnormal counts, the morphology, and the molecular analysis, this was consistent with chronic phase of CML. This is a microscopic description in the bone marrow report that talks about every single series of the cells or lineage that is seen in the bone marrow. And then if any immunostains are performed, we mention those in the report as well. Here is the differential, peripheral blood differential count that was performed in this patient, incorporated in the report. Here is the bone marrow differential count. So bone marrow counts, usually we do a 500 cell count on the bone marrow aspirate to give an accurate percentage of these different cells, because it's very important to know what the blast count is in patients with chronic myelogenous leukemia. If it's less than 20%, it's still in the chronic phase or could be accelerated phase. But if it is more than 20%, then it's treated as an acute leukemia. So the differential count is very, very important in the marrow. So here's a cytogenetic karyotype in this patient, and you can see that there's an arrow by chromosome 9 and chromosome 22. So there's a classic translocation of 922, which leads to the BCR-ABL fusion transcript, and that's hallmark for CML diagnosis. All right, so a brief summary of the diagnostic approach in these 5 cases. The first patient, we didn't do a lot of testing after we looked at the CBC and the morphology, and we were able to make the infectious mononucleosis diagnosis based on monospot test, ultrasound, and some other testing that was done in it, and we avoided doing flow cytometry, cytogenetic, or all these tests. And it's also important for a hematopathologist to kind of do a very focused and efficient workup in order to make an accurate diagnosis and also not overdo things, because all of these tests end up costing a lot. And if it's unnecessary, sometimes they're not reimbursed by the insurance companies as well. So it's very important to know what tests you want. So the second patient, we actually did go ahead and do flow cytometry and FISH for diagnosis. And that was very classic, CLL. There are other additional abnormalities that are not needed for diagnosis, but they have some prognostic implications. And we do them just to give clinicians some information about how the disease is going to behave, because some abnormalities will have poor prognosis. In patients with mantle cell lymphoma, again, we were able to make the diagnosis after flow cytometry confirmed with the FISH study. And again, TP53 mutation can be done, but not needed for diagnosis. The hairy cell leukemia case was very classic, diagnosed by the flow cytometry and morphology. And BRAF mutation is good to have because sometimes in the follow-up cases, this will help to kind of track the patient, but it's not really needed for diagnosis. In CML, again, we were able to make the diagnosis. CBC and peripheral smear review were very abnormal. A flow cytometry is helpful and it does give some additional information, but usually it's not very diagnostic. So you have to have the 922 translocation to call this CML. So that's a hallmark translocation. And in some patients, you have to do molecular analysis to define what type of transcript it is, because there are three different types of transcripts that will help in the future follow-up of the patient. And also look at the ABL mutation. The mutation in the ABL gene is important to identify because these patients will have resistance for the tyrosine kinase inhibitor therapy. So it's not needed for diagnosis, but usually helpful for prognosis and treatment purposes. So this was basically an overview of how the diagnostic workup leads to the accurate and more efficient diagnosis. So just some take-home points is that as a hematopathologist, you require expertise in interpretation of multiple diagnostic modalities. You can do a careful review of the CBC because it can provide a tremendous amount of information, and it can trigger a recommendation for further testing. And there are many morphologic and immunophenotypic overlaps between various hematologic malignancies. And we saw the example of CLL and mantle cell because phenotypically they both are CD5 positive, but then there are subtle things that are different in the phenotype morphology. And then the confirmatory test is to identify the translocation 1114 for mantle cell lymphoma. So a stepwise reflex testing and diagnostic approach is important that leads to an accurate final diagnosis. And then, a hematopathologist should be familiar with the genetic hallmarks of certain hematologic malignancies so that they can do focused testing to come up with the appropriate diagnosis and do an efficient workup. All right, so that's the end of my talk. And if you have any questions, please feel free to ask.
Thank you so much for your sharing your career journey, mentorship, and teaching, Dr. Qureishi. We'll now begin our Q&A session. So I'll be asking you some questions related to your career path and specialty. Let me slide. So the first question is, what got you interested in pursuing the pathology specialty?
Pathology specialty. I think my inspiration came from my medical school pathology teacher. So I was in my third year when I was introduced to pathology, and we just had a very enthusiastic teacher. Loved her teaching style, and it became one of my favorite subjects in my third year. And when I came to the US, I was early on interested in hematology and hempath. So I already had decided that I was going to do a hempath fellowship.
That's very inspiring. It's like how you are to some of these students online today. I'm sure you've inspired some students today. So our next question is, why did you choose to pursue a fellowship in hematopathology?
Fellowship. So in the residency program, which is a 4-year APCP combined program, the residents are exposed to HemePath, but I mean, they have limited amount of rotations that they do on the lymph node bench and the bone marrow bench. There are not many, there are some opportunities to do research, but because you are juggling a lot of, different components of the pathology residency, it's sometimes very difficult to have a very good, thorough, focused experience in HemePath. So the fellowship, the difference between the residency and the fellowship is, I would say it's two-tier. First is that you're really focused on learning all these ancillary technologies, and that requires some time and focus, because as a resident, you get an overview of all these, you see and experience the flow cytometry, cytogenetics, and learn the basics. But in order to get more in-depth experience, you really have to have a longer experience. And a lot of the HemePath fellowships, they provide that. And number two is, you get to have a focused research experience in HemePath. And once you do a research, you understand a lot of the biology of the diseases. And that's a key thing in understanding the disease process, and that helps in the diagnosis as well. And thirdly, diagnosing, hematologic malignancies as a resident actually is not very easy. And if you ask a lot of the residents, they think that HemePath is pretty hard. So the fellowship actually helps you gain the experience to become an independent hematopathologist and sign out the cases independently. And signing out cases is not very easy in the beginning, because as a resident, as a fellow, you are working with your attending, you're looking at the cases, you're coming up with the diagnosis, but still your hand is kind of held a little bit by your attending, and they are the ones who are finally releasing the report and signing it out. So all the burden is on the attending, actually. So once you do a fellowship, you gain that experience under a very graduated, responsibility, and you're able to very confidently, make all these diagnoses. So I think fellowships are very, very important nowadays.
Thank you so much for the detailed answer. So the next question. So personally, one thing we are told in school is that pathologists and radiologists have limited interaction with patients, and if we prefer to work without them, so we should become a pathologist. So how much time do you personally spend with patients, or do you spend more time analyzing and diagnosing patient tissue in the lab?
No, actually, I do not interact with patients now. So most of my time is mainly analyzing the data and analyzing the samples. But when I started my academic career, I used to run a bone marrow clinic. So there are a couple of areas in pathology where you can actually have some patient interaction. So I used to actually do the bone marrow biopsies myself, and I used to run a bone marrow clinic, and I was able to interact with the patients. The other part where you can interact is the FNA clinic, usually in cytology. The pathologists are actually going and doing the fine needle aspirate on the patients. So you're taking patient history, you're doing the consent, and you're doing the procedure, and you're actually making the diagnosis. So it does help to actually, when I did the bone marrow clinic, it did help me a lot to not just only understand the disease, but also to understand, the presentation, and talking to the patient was a little bit, a very good experience. But a lot of the pathologists, they don't really get a lot of direct patient interaction. I think a few years back, one of the new developments was, and I'm not sure if you guys are familiar, in Epic system, which is the electronic medical record system here in the US, a lot of times the results were released to the physicians before they're sent to the patient. That was historically the case. But a few years back, due to some legislation, now the results are actually released to the patient immediately, and sometimes the patient may not even see it. So there have been some instances where we actually get a phone call from a patient. They might call the pathologist. So, I mean, I usually like those types of interactions, but it's not very common.
Got it. Thank you. So as a senior hematopathologist, what is your day-to-day schedule at work like?
So my day-to-day schedule is now it's actually pretty flexible. I chose to work in a commercial lab setting. I work pretty independently, and depending on my caseload, usually I start working, on the peripheral bloods and bone marrows and lymph node biopsies during the day, and usually I'm done by 4 or 5, which is a very good kind of lifestyle at this stage of my life. And the reason that I chose this is because in an academic setting, you are part of a multidisciplinary team. And in addition to doing clinical work, there is a lot of other responsibilities as well. So if you, are on a clinical track and you're doing your clinical cases, you have to find time, and you do get that protected time in an academic setting to do other, pursue some other, things as well in teaching, research. In my current position, I'm not involved that much in research anymore, and purely focused on the clinical diagnosis and developing and helping the companies developing new technology as well. So it's a pretty good work day, and usually I don't get any calls on the weekends, so that's also a plus.
And that's great that you mentioned research, because some students were interested in like pursuing research opportunities in pathology to figure out if this is the right field for them to pursue. So can you just tell us a little bit more about your past research experience, projects, and if you have any other recommendations for things students should be doing if they are interested in pursuing pathology?
Yeah, I think you should explore research because, as I said, it not only gives you an opportunity to learn the biology of the disease, but it also gives you an opportunity to kind of network with people in the department and really hone the skills in research, because not everybody is good in writing, is good in analyzing the data. So if you get that experience, it's I would say it's a golden opportunity to get research experience.
All right. Those are all of our questions for today. Thank you so much, Dr. Qureishi. We really appreciate you taking the time out of your day to mentor us. And I'd love everyone to please give a warm thank you to Dr. Qureishi in the chat box for this incredibly informative session.
Thank you so much. It was a pleasure. Thank you.
Thank you. Okay, so the link to the quiz for this session is now live. And again, you will need a 70% or higher to pass and receive certification. And that link is being sent in the chat box now. Now on to our next session dates. These links will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session next Saturday, April 22nd at 12 p.m. Eastern Standard Time for a physician mentoring us in gastrointestinal pathology. Thank you so much to everyone for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.